Hello, welcome to our brochure on lung adenocarcinomas and the replicative immortality hallmark. So, lung adenocarcinomas are categorized as a form of non-small cell lung cancer, and they're the most common primary lung cancer in the United States. Mutations in the p53 gene, which is a tumor-suppressing gene under normal conditions, is the most common cause of non-small cell lung cancer tumor formation. Some risk factors include smoking, where primary and secondary exposure both cause risk, family history of lung cancer, and occupational exposure to carcinogenic agents such as asbestos. Common symptoms include persistent cough, shortness of breath, chest pain, coughing up blood, and unexplained weight loss. Replicative immortality is a hallmark of cancer in which mutated cells are allowed to continuously grow and divide uncontrollably and eventually form a tumor. Normal somatic cells have a finite capacity to divide around 40 to 60 times, which is known as the Hayflick limit. Once a cell has reached the Hayflick limit, it goes into a senescent state in which it is alive but cannot grow or divide any longer.
How do cells know when they have reached the Hayflick limit? Cells know when to stop dividing due to their telomeres. The same sequence of 6 nucleotides, TTA-GGG, repeated over and over again at the end of chromosomes. Telomeres act like a protective cap, preventing chromosomes from sticking to each other. With each division, about 50 to 100 nucleotides of telomeric DNA are lost. When the telomeres become too short to continue cell division, the cell switches to the senescent state. On the other hand, there is an enzyme called telomerase, which is capable of extending the length of telomeres. It consists of two subunits, first one being HERT, which stands for human telomerase reverse transcriptase and is encoded by the TERT gene on chromosome 5, and the second subunit being HRT, which stands for human telomerase RNA and is encoded by TERT gene on chromosome 3. It is to be noted that normal human cells do not express telomerase.
Be active.
Now we will be discussing treatment options for lung adenocarcinoma. One effective first-line treatment for lung adenocarcinoma is using an epidermal growth factor receptor tyrosine kinase inhibitor, such as gefitinib and erlotinib for lung adenocarcinomas that contain EGFR mutations. Many tumors have a mutation in the EGFR. These mutations occur near the ATP cleft in the tyrosine kinase domain, which can cause increased receptor activation and drive oncogenesis. These mutations are driver mutations. Normally, when a ligand binds to the EGFR, it causes a conformational change to occur, and the receptor will homo- or heterodimerize with other human epidermal growth factor receptors, and autophosphorylation will occur in the cytoplasmic domain of the receptor. This triggers signaling pathways such as RAS, RAF, MAPK, PI3K, PKB, AKT pathways, which stimulates mitosis and causes cell proliferation and inhibition of cell death. Gefitinib and erlotinib bind reversibly to the ATP binding site on the EGFR to block ATP from binding and block its downstream signaling pathways, leading to apoptosis. These inhibitors increase the level of pro-apoptotic cell death effect in the EGFR pathway. Erlotinib inhibits cell growth by causing arrest in G1/S phase of the cell cycle through the suppression of cyclins and increased production of CDK inhibitors, for example, P27. Some cells can develop resistance to this treatment through the development of new mutations. In this case, you can do combined therapy using tyrosine kinase inhibitors combined with platinum-based chemotherapy. Another treatment is using an antibody to target vascular endothelial growth factor, which has increased expression in some cancers. VEGF is involved in blood vessel formation. Bevacizumab is an antibody targeted to VEGF and is effective with other cytotoxic chemotherapies.
Future drug therapies for lung adenocarcinomas. Currently, EGFR TKIs are used as a first-line treatment for non-small cell lung cancers, such as lung adenocarcinomas, but further research can still be done to improve them. As of now, ruxolitinib is in preclinical studies and is poised to replace current therapies which include neratinib, dacomitinib, and afatinib. The reason why ruxolitinib is so much better than current therapies is because it has the ability to only target tumor cells that have a EGFR mutation, sparing the healthy surrounding tissue, therefore decreasing dose-limiting toxicity and increasing overall drug efficacy. Also, this therapy has seen decreased side effects with no adverse skin conditions. Also, there's been new research in drug combinations, which are being developed for NSCLC. Tarceva or chemotherapy, also known as TORCH, is developing a drug combination. It is in phase 3 trials. The new drug combination uses erlotinib, then chemotherapy using cisplatin and gemcitabine, rather than the reverse order. This drug therapy study is evaluating what is the most appropriate drug combination using erlotinib and chemotherapy for the best overall result.